the slides. Okay, so I will be moderating this session. I'm Dr. Muhammad Al-Amri. Next, please. My dear friends, Dr. Majdi Musa, Professor of Ophthalmology and VR Consultant, Director of Medical Retina, Faculty of Medicine, Tanta University. He is going to be the co-moderator. Next, please. And our first speakers now, my dear friends, first time we are having, but as if we are knowing him a long time, Dr. Abdullah Al-Labban. He is a cataract and vitreoretinal surgeon, Hull University Teaching Hospital, NH Trust UK. Dr. Abdullah, he will give a talk about multimodal imaging in myopic macular disorders. Dr. Abdullah, the mic with you, please.
Hello, thank you very much, Dr. Mohammed, for the kind invitation, and it's my great pleasure to be here with you today and with my Professor Magdi and all the friends. I'll just share my presentation now. So, can you see my presentation?
Yes, I can see it, please.
Oh, fantastic. So, today I'll quickly take you through the journey of the multimodal imaging of myopic macular disorders and through what we have learned from multimodal imaging, and I'll try to provide you with some clinical tips as we all see these cases from day-to-day practice. One tip is essential to differentiate between high myopia, which just essentially increased refractive error, and those with pathological myopia, where you find some degenerative changes in the fundus. And also in myopia, or high myopia, there are two types. Ones which are just a very simple elongation of the globe, but some of those may develop staphyloma. So not all high myopia cases have staphyloma. And the staphyloma, as you know, can appear in many shapes and several trials to classify them, but the most popular is the Curtin classification, dividing them into primary staphyloma. The most commonly seen one, those in the posterior pool, mainly involving the disc and the macula. And there are like secondary types, which is a little bit more complex types of staphyloma, which is a bit behind our discussion today. But we'll focus on these myopic changes. And another trial to classify the macular changes, as we all know, like ciliated fundus, atrophy, myopic CNV, and lacquer cracks. But with the advent of the multimodal imaging, we learned that there are few other changes which actually more essential to correlate them with visual changes in myopia. And I'll take you quickly through each of these. So let's start by this simple case. This patient, 45 years, vision 612, myopia -8.5. You see myopic changes, you expect that also there is a little bit of staphylomatous changes here, but you can't appreciate the changes. Interestingly, when you do OCT for these patients, you see multiple changes here. You can see like outer retinal scases, fovea scases, also the outer retina changed to like a columnar-like structures. And there is a small foveal detachment. Interestingly, when you do a 3D imaging, you can see hardly how the inner retina is split from the outer retina. Previously, we were unable to see these changes, and in fluorescein and ICG, you can hardly pick up any change. But when you focus on that, this is actually simply because the inelasticity of the inner part of the retina compared to the outer retina, and this leads to the stretch of the retina, forming these schitic changes. And that's why I often recommend to perform OCT, at least OCT and better OCTA as well for all patients with high myopia, especially those coming with any level of visual symptom. With myopic fovea scases, it can present with different shapes, and like here with epiretinal membrane, or sometimes with a focal foveal detachment, sometimes with lamellar defects, and some of these cases may progress to like a full thickness hole and develop macular detachment. Another interesting finding we learned from multimodal imaging, these orange-like changes which we usually thought as a part of peripapillary changes, but with multimodal imaging, these were highlighted and given the term peripapillary intrachoroidal cavitation. They are seen usually around the disc, hence the name peripapillary. They are cavity-like changes, and sometimes they may have a communication with the vitreous. Interestingly, they are seen in about 5 to 10% of cases, which means like 1 out of 10. So they are more common than what we thought. And as you all know, it's very challenging to assess the optic nerve in high myopia, and it's even more challenging to assess the visual field in these cases. And the presence of these cavitation may cause like a visual field defects that can mimic glaucoma. Dr. Spade nicely highlighted this could be due to the defect at the level of the border tissue of Jacobi at the edge of the nerve. The cause of it unknown, but it's possibly within the spectrum of the myopia. With multimodal imaging, they show well actually in the fundus color photographs, and they show well on the late fluorescein compared to other tools. The third most common thing we often see in our practice is myopic CNV, and it is the most visually challenging complication of myopia. With multimodal imaging, we can quantify the myopic CNV, especially with fluorescein and ICG and OCT. It's usually a form of type 2 CNV where the proliferation develop within the retina. And OCT is very useful, especially in myopic CNVs, because they tend to be less vascular compared to other types of CNV. And sometimes even in our clinical practice, we see these small hemorrhages, and we are not sure whether these hemorrhages are just a simple hemorrhage coming from a liquor crack or a myopic CNV. There are few ways to differentiate between them with multimodal imaging, particularly using OCT and OCTA. However, it's not easy in every cases, and every now and then you may come a case where you find it challenging to differentiate between them. And my clinical tip here is always good. You can wait for 2 or 3 weeks and repeat the scans. And if it's a simple hemorrhage, usually it will slightly resolve over time. But if it's a myopic CNV, it usually will cause further leak. Another interesting entity in high myopia is what we call dome-shaped macula. As you know, the curvature of the posterior bole, especially with those with high myopia, we expect it to be a steep curvature, but some certain patients, they have like this dome-shaped configuration when imaged with OCT, and this is very unusual. Interestingly, when we did a study on these cases, and we found that even some of these cases, they have this dome-shaped configuration on the vertical scan rather than the horizontal scan. And we try to quantify these patients, and by simply measuring what we call the macular bulge, which is the bulge of the sclera, if you draw a tangent line at the outer border of the retina. And interestingly, with the 3D OCT, the configuration is slightly more complex than what we thought. So these patients, they tend to have like 2 concavities, and there is something like an anal ridge between them. And with all these cases, this, what we call band-shaped configuration, is possibly the most common in about 80% of cases. But the typical, what we call typical dome configuration, will you see the macula has a little bit of dome-like elevation. It's only in 20% of cases. This condition is important because about 60% of cases with dome-shaped macula develop macular problems, particularly CNV and serous detachment. And sometimes this serous detachment can be mixed with myopic CNV, so differentiating the 2 conditions is essential with the help of multimodal imaging. They also may develop other complications like scetic changes or even sometimes full thickness macular holes. We further checked these cases and thought what will happen in these cases, and we monitored some of these cases over 2 years just to understand the pathomorphology of the changes that occur in high myopia. And this patient, as an example, monitored for nearly 3 years. Interestingly, when you analyze the image, you see this bulge slightly increases over time, which means that the three-dimensional change is that this concavity gets deep over time. And just to highlighting this change, if you draw a line B tangent to line A, you will appreciate the deepening of the concavities here, which is increasing day by day. So moving to another interesting finding we learned it in high myopia is the biovascular changes. And if you look at this patient, it doesn't look that very highly myopic. He has just simply like an axial elongation. But when you look at these blood vessels, you can see a little bit of change in the color of the retina around these blood vessels. With careful looking using the infrared imaging, you can see as if these are some defects. And we term it that biovascular anal retinal defects. With 3D imaging, these defects appears to be like some sort of retinal nerve fiber layer thinning. And this has a strong correlation with visual field defects and can simply mimic glaucoma. And you may be surprised that you may see some of these changes during retinal surgery, and really challenging to treat because this area of the retina will detach easily during the surgery. These defects, there are also some other biovascular changes like the cystoid changes, which are mainly due to a stretch of the globe. Another common change is the tractional detachment of the renal retinal membrane, which is important to differentiate between ERM, especially if you are planning surgery. Also, we learned about retroocular tissue. I'll go quickly because running out of time. You can see this clear border. We can also see the retroocular fat. Sometimes we're able to pick up like perforating scleral vessels, or sometimes you can see the orbital fat, or occasionally sometimes we pick up interesting structures as this thought to be the insertion of the inferior oblique muscle. So in summary, especially with highly myopic cases, we need to have like a protocol in our mind, looking into all the layers and utilize the multimodal imaging in our analysis. Thank you very much.
Thank you very much, Dr. Abdullah, for this an excellent presentation. As we are running behind the times, if we can just keep the question and discussion until the end, or if Dr. Majdi wants to do the discussion now.
Thank you, Dr. Abdullah, for this nice presentation. You wrapped up everything. Thank you. It's nice to see you after that long time. It's very nice to see you.
I miss you so much.
I have only one comment or question for you. You didn't mention much about CNV in high myopia, which is one of the devastating things you see in high myopia. And sometimes if you use all the multimodal imaging, fluorescein, OCT, angiography, sometimes you still questionable. Is it a CNV? Is it an active or it's inactive? So what's your answer about that? What do you feel about this?
It's very challenging. I totally agree with you. And sometimes, so I slightly highlighted one of the common issues where you see just a tiny hemorrhage and you are not sure whether it's just a simple hemorrhage or a CNV. You can use the different modalities. Sometimes they are helpful, like OCT, OCTA. But one clinical tip, if you are not sure, you can wait like 2 to 3 weeks, repeat the scan, see if any change. If CNV leaking, it may progress slightly. If it's a hemorrhage, it's usually a simple hemorrhage and usually resolves over time. And this may help to avoid any unnecessary injection. But also looking, if you confirm the diagnosis, it's a CNV, and whether it's leaking or not, we usually rely on the exudative features. If any exudative feature, we can treat. If inactive, we just observe. But however, in clinical practice, in some cases, you are not really sure. And sometimes you may consider a therapeutic injection. So just give one injection and see if they respond or not. You know, the treatment for myopic CNV is slightly, with injection, is slightly different from other conditions like wet AMD or other diabetic macular edema. You can just try simply one injection and see how it goes.
That's very good answer. Covered all my answers except one more thing. There's the patient symptoms. Sometimes I do inject when I feel that the patient is suffering from metamorphopsia, because metamorphopsia sometimes does not show anything on OCT or OCTA, and still the patient is bothered. So that's why I give one injection and see if metamorphopsia is gone. That's it. It means that the patient will be satisfied after that. So another thing, look at the vision, look at the patient symptom, plus all the multimodal imaging. This is a very good point. Thank you, Dr. Abdullah. Thank you so much.
Thank you. Thank you very much.
Thank you very much, Dr. Abdullah, Dr. Majdi. Dr. Sibyl, you have any comment, question, Dr. Amaya, or any others of your colleagues?
It was a great talk. No question.
Oh, thank you very much.
Okay, Dr. Amaya. You are with us, Dr. Amaya?
Thank you. Excellent presentation.
Okay.
This will make me work more with my equipment.
Thank you very much.
Okay, so can you show me, please, the second speakers, please? Okay, so now we will go to Dr. Sibyl Zemirel, and she's an MD, Associate Professor of Ophthalmology, Ankara University Faculty of Medicine Department of Ophthalmology, and VHP Kosi, I don't know, Eye Hospital, Ankara. And she's going to talk about central serous chorioretinopathy. We are glad also to have Dr. Sibyl with us today. Dr. Sibyl, the mic with you.
I'd like to thank the organizing committee for having me here. It's great to be here with our colleagues. Today, I'll talk about the current treatment options for central serous chorioretinopathy. Central serous chorioretinopathy causes unilateral visual loss, usually in male, due to development of subretinal fluid, and typically between the ages 20 and 50 years old. CSR is the fourth common retinopathy after age-related macular degeneration, diabetic retinopathy, and branch retinal vein occlusion. And the disease is thought to occur due to hyperpermeable choroidal capillaries in association with Rpe dysfunction. And finally, these factors cause a serous retinal detachment of the macula. Acute CSR is a self-limited condition with resolution of retinal detachment and generally good recovery of visual acuity within 3 months. However, 15% of the patients may show persistent subretinal fluid for greater than 6 months and are diagnosed with chronic central serous chorioretinopathy. Timely effective treatment that provides total subretinal resolution and prevents recurrence should be applied. We know that the 10% of the chronic cases have visual acuity drop to legal blindness level. And in these cases, a persistent subretinal fluid can lead to progressive and irreversible damage to photoreceptor, resulting in both poor visual prognosis and decline in quality of life among these relatively young patients. Exogenous steroids of any route has been strongly linked to the increased risk of CSR, even at low doses, as we all know that, and discontinuation of the steroids is highly recommended. However, the modification of these factors, other factors such as type A personality, Helicobacter pylori, have not yielded consistent results like discontinuation of the exogenous steroids. Current treatment approaches can be listed as follows: photodynamic therapy, micropulse laser photostimulation, argon laser photocoagulation, and the others such as anti-VEGF injections and oral eplerenone treatment. Argon laser photocoagulation, thermal laser photocoagulation was used to treat cases with persistent fluid and visual loss, and it is hypothesized that destruction of these detached sites allows scarring and that reattach the retina. For patients with extrafoveal leaking points, focal argon laser photocoagulation might be considered for these cases. However, this treatment option doesn't reduce the recurrence rate. We should keep in mind that, and we have to always check our patients regarding choroidal neovascularization at the site of the treatment. The use of antivascular endothelial growth factor agents are based on the idea that the VEGF level may be elevated due to the choroidal pathology. However, studies have shown that the VEGF level are similar between the diseased eyes and the control eyes. And it was shown that the recurrence rate after total resolution is pretty high in these cases, and meta-analysis of 4 control studies with patients treated with intravitreal bevacizumab compared to control group, no improvements in best corrected visual acuity or CMP at 6 months. And in another control study that evaluated total resolution rate after treatment, it was shown that the resolution rate in almost 13% of the cases in anti-VEGF group compared to 90% in PDT group. Of note, the patients with coexistent choroidal neovascularization and CSR do benefit from anti-VEGF therapy. Subthreshold micropyle laser, also known as high-density, low-intensity laser, uses subthreshold energy that selectively targets RPE cells without inducing any damage or scarring, and the laser is applied in pulses in a frequency that allows heat dissipation and to prevent structural heat damage to the retina. Several uncontrolled studies, in addition, our study have shown the effectiveness of this laser. A study comparing micropulse laser with PDT in the treatment of chronic CSR in a retrospective manner showed that a good treatment response in micropulse laser like PDT without any potential side effects, such as choroidal neovascularization, Rpe atrophy, etc. However, PLACE trial came up, and this is a cornerstone study that shed light for the treatment of CSR. This is a prospective multicenter control study that directly compared both safety and efficacy of half-dose PDT and micropulse laser, and they found that the efficacy of half-dose PDT with respect to complete resolution of CSR was significantly higher compared to micropulse treatment at both short-term and long-term follow-up visits. Moreover, functional outcome was better after half-dose PDT compared to micropulse laser treatment with respect to both increased retinal sensitivity at the first and final evolution and increased best-corrected visual acuity at the first evolution. Expansion part of PLACE trial was called PLACE trial, and in this study, CSR patients with persistent fluid at the final visit of PLACE trial were crossed over to another option as a treatment. And finally, almost 80% of the patients in PDT group had complete resolution of subretinal fluid, while none of the micropulse treated patients had complete resolution of subretinal fluid. Still, the numbers coming from the trials show that 1/3 of patients may benefit from the micropulse laser, and studies show that this group is mostly acute CSR cases or chronic CSR cases with focal leakage without diffuse Rpe atrophy. Unfavorable side effects have led to the development of safer version of PDT, as we all know that, which is half-fluence or half-dose PDT. And in chronic CSR cases, half-dose PDT has been reported to be either as effective as half-fluence PDT or superior to half-fluence PDT. But right now, we can use both options safely. Photodynamic therapy is thought to lead to short-term hypoperfusion of the choroidal capillaries and subsequently to long-term remodeling of choroidal vasculature and reduction of the increased thickness of the choroid and large choroidal vessels, which in turn leads to a resolution of subretinal fluid. And our study showed that hypoperfusion of choroidal capillaries seen before treatment get back to normal level, like what we see in the other healthy fellow eyes. So we think that also the papers coming from the literature show that it's a very safe treatment option. Here are some results of extremely chronic cases benefited from PDT treatment without any recurrence over 4 to 5 years. This is the first one, as you see here, after PDT without any recurrence for 4 years. And this is another one after one PDT session, 5 years without any recurrence in this case. PDT might not be effective in some patients, of course, maybe in 20 or 30% of the patients. And reasons for that can be listed as diffuse hypercyanescence in the signing green angiography, diffuse Rpe atrophy, the eyes complicated with CNV, and the older age group. And the reason for recurrence after successful treatment can be listed as follows, as you see here: systemic degeneration, poor baseline best-corrected visual acuity, and disrupted ellipsoid zone. But it's important to rule out the most important one, rule out the presence of subretinal neovascularization, type 1 neovascularization, in patients with recurrence fluid. So speaking of choroidal neovascularization, OCT angiography is a superior imaging technique to show type 1 CNV in these cases compared to dye angiography. If you don't have any neovascularization under the retinal pigment epithelium, you can use ICG-guided half-dose or half-fluence PDT again for the treatment option for these cases, and intravitreal injection should be prescribed to patients with a subretinal neovascularization. However, we have to keep in mind that some of the PACI-CNV cases might benefit from the PDT treatment as well, in contrast to age-related macular degeneration. And in this study, we evaluated effect of PDT for the treatment of Myopic Cnv and found that the 75% of the patients had total resolution in the small group of patients, although it was not as good as or as high as the result what we see in CSR cases without choroidal neovascularization, but it is still the option for these cases. Finally, since PDT is invasive, expensive, and not broadly available right now, there has been considerable interest in developing alternative therapies. Recently, the use of mineralocorticoid antagonists has gained interest as a potential simple oral therapeutic option for patients with CSR. And as we all know that the mineralocorticoids are known to have an impact on choroidal vasculature. However, again, then Rpe trial came up to evaluate the effect of this treatment as a randomized double-blind placebo-controlled study conducted in UK. Patients were treated with eplerenone or placebo for a period of 12 months, and overall the Rpe trial observed no significant benefit of eplerenone with regards to distance visual acuity or with respect to resolution of fluid and the time to recurrence. And prospective randomized trial of maybe spironolactone required in order to exclude the potential relevance of mineralocorticoid antagonism in the treatment of CSR. As a summary, half-dose or half-length PDT is the most effective treatment option for CSR cases according to the current literature. Micropulse laser might be an alternative only for the cases with focal leaking points. Anti-VEGF injection is suitable for the cases complicated with choroidal neovascularization. And eplerenone seems to be a safe treatment option. However, the effect of it seems limited for CSR cases. Thank you very much for your attention.
Thank you very much, Dr. Sibel. Very nice and excellent comprehensive presentation. Is there any question from our colleagues here? Dr. Majdi, Maya, and Dr. Abdullah?
Can I have a question?
Please.
Dr. Sibel, thank you so much for summarizing all the treatment modality. But do you think any of these modality prevent recurrence of CSC? I mean, all my experience, I don't have much experience with PDT, as you know, but we don't have it in Egypt since decades. But the point is, all other modalities does not prevent recurrence. How about PDT? What's the recurrence rate after PDT?
Thank you very much. Very nice to see you and meet you here.
Thank you.
And we have many experience in Turkey. Actually, we had these drugs a year ago. And I broadly use this option for central sclerosis cases as a first treatment option. So yes, I can say definitely yes. Photodynamic therapy prevents the recurrences in chronic CSR cases. And this is the only option that prevents recurrence, I can say. Maybe 6% up to maybe 20% according to the literature during very long time, I mean, the over 5 years. So it's a pretty good number, I believe, and it's very successful treatment option.
Thank you. Nice to see you.
Any other questions? Yeah.
Thank you, Saibel, for very interesting. And I totally agree with you. We have the same experience here that half-dose PDT is the most effective treatment. And we have similar experience. The recurrence is low, but there are still some cases with recurrence due to one or more reason. The major problem that Dr. Magdi is that there is a worldwide shortage of PDT, and we just recently started. So there was like a year and a half of worldwide shortage of Visiodine, and we just recently got some of the vials recently, and we are able to resume treatment. But I strongly recommend starting half-dose PDT for chronic cases. What we do in our practice, we look at the baseline fluorescein and ICG. If you have like one or two small focal spots, sometimes we classify that as classic CSC. But if you have like a diffuse patch of pinpoint hyperfluorescence, it's cases where you see RBE dysfunction, and these cases are those who tend to be chronic. So we use this simple classification for using fluorescein. So we identify the cases who will benefit from half-dose PDT from the beginning. And if you give it on a timely manner, it usually works well. But if you wait and the patient observe it for a long time and then you start the treatment, it's not as effective as when it started promptly. And these cases, if you start the treatment late, even the subretinal fluid resolves, you start to notice some foveal thinning with some damage of the photoreceptor, which has significant impact on the final visual acuity.
Thank you very much, Dr. Abdullah. Yeah, any response, Dr. Sibel, you have to comment or?
No, I totally agree with Abdullah's opinion. Yes, we have to hurry regarding the treatment. Actually, if you don't have any resolution for 2 months maximum, in my opinion, we have to do something for these patients, even if the focal leakage point.
Okay, Dr. Maya, you have any questions?
Actually, a small comment. In the absence of PDT, I think OCT angio is giving a very nice clue to the presence of a neovascular membrane or suspicious area under the pigment epithelium. I started giving anti-VEGF more than 10 years ago, actually with the beginning of availability of Lucentis. And I found that 1 or 2 injections, even in the chronic case, are quite useful. As Dr. Majdi mentioned, we cannot prevent the recurrences. However, the response is nice and without any side effects. There is no central defect in the visual field, even though the macular edema was substantial and chronic for a while. The problems are the patients in the more advanced stage. They are having much more recurrences. And I think it is essential to treat aggressively before the edema has become chronic, as our colleague Dr. Sibel mentioned. Thank you.
Thank you very much, Dr. Maya. There is a question from Dr. Brasan, Dr. Sibel. He is mentioning about the role of melatonin in central cellular choroidal retinopathy.
There are some papers in the literature. I never use it for the treatment of these cases, and the people believe that the melatonin can have some anti-cortisol effect, and that's why some people use it. And we have some results, but they are not. There is no consistency regarding the results, and that's why I have no experience actually for the melatonin use.
Dr. Abdullah, you have any experience with that, or Dr. Majdi?
No, from our side, no, I've never used it. There's no evidence, realistic evidence about melatonin or CSC.
Yes.
There was only eplerenone, and there was some people were using it, and you get some sporadic cases of response. But this was a large study that Saibel mentioned, the one by Professor Lottery, mentioning that there is no difference between it and placebo. So unfortunately, we don't have many options in CSC. We only have reduced fluence BDT for chronic cases, and in some selective cases for extramacular leak, focal laser can work. But just focal laser, it works in some selective cases, but focal laser doesn't treat the pathology. Focal laser causes some therapeutic damage at the area of the leak. But if you compare it with reduced fluence BDT, after BDT, you start to see the choroidal thickness decreases over time. So in a way or another, it treats the pathology itself. And some people do it.
Okay, thank you, Dr. Abdullah. I think we can move to the next speakers. And now, I think Dr. Raja is not with us, so we can move to the next, please. So, Dr. Maya,
sorry, sir, we have received his video, sir. Recorded talk. Yes, sir. Just now, sir.
Just now. Okay.
So should I play it?
Me about. Okay, can we keep it to the end, please? If we can now, please have Dr. Maya.
As you wish, sir.
Okay. Can you show me the slide? Okay. So now the presentation is Dr. Maya Pandova. Please show me the slide again. She will talk about Dr. Maya. She's a specialist ophthalmologist. She is in OCA Hospital, Ahmed, Kuwait. So she's going to talk about neovascular AMD, first result of treatment on POV. Dr. Maya, please.
Thank you. Until recently, thank you very much for the invitation. It's a challenging topic, but it was your choice, Dr. Ahmed, Dr. Muhammad. Until recently, we had approval from the FDA on 2 major agents for treatment of neovascular AMD. Since the FDA approval of brolucizumab in 2019, we started looking into more options, particularly in more challenging cases. The smaller molecule, the higher concentration, and the higher penetration of the new molecule for giving us better options. The 2 pivotal studies presented unexpected and unprecedented improvement in the resolution of the intraretinal fluid, unlike the aflibercept fluctuations. In both pivotal studies, the brolucizumab 6 milligrams were providing excellent results and large intervals between the injections up to 3-4 weeks. The complete resolution was much more frequently seen in the eyes treated by 6 milligrams of brolucizumab compared to aflibercept. However, even in the pivotal presentation of Professor Dugel, we saw a higher proportion of intraocular inflammation and unusual events like occlusive vasculitis. And these events are happening approximately 100 days from the onset of treatment, and the inflammation is usually happening within 18 days after the injection in the pivotal studies again. However, we need to keep in mind that even though the percentage of intraocular inflammation is around 4% in the pivotal trial, actually the vision loss associated with occlusive vasculitis is less than 1%. Now, having in mind all these warning signs, we had to consider our options, how we can introduce and for who. And that is what we did. In the June of last year, we started on a very small group of patients with neovascular AMD that was verified with appropriate examinations. The patients had incomplete and unstable response to ranibizumab and aflibercept despite switching between agents and fairly intensive treatment. They had deteriorating visual acuity despite the treatment, no previous inflammations, no uveitis, no central branch vein occlusions, and no decompensated systemic autoimmune diseases. Let us look at one of the first cases. This is a 64-year-old man without diabetes, neovascular AMD that is causing me headache for the last 7 years. He had multiple injections, and actually his vision was not that bad until the beginning of the lockdown, when his treatment was interrupted for 5 months. From 2050 vision dropped to 2200. He had severe edema recurrence, his membrane was leaking, and despite intensive treatment, he had incomplete unstable response to Eylea, and the vision remained in the same range, 20 over 150. Now, this is the typical story from 2020. You see how much his edema is recurring, and then recurring again, and decompensating again and again until April, May last year. You can see the hemorrhages and the diffuse granulated appearance on the autofluorescence with a fairly large atrophic area right in the macula that was associated with an active neovascular membrane well visualized in this custom slab. Despite the Eylea treatment, you see he's still having intraretinal cystic changes, quite highly active membrane. So that is what happened after the 5 days. And after 3 months of loading dose of brolucizumab, you see how the edema is subsiding beautifully. And despite this fact, after the 3rd injection, there was still a bit of fluid collection on the superior-temporal quadrant of the macula that went on to disappear after the additional injection. To our greatest relief, the vision of the patient improved to 20/50/20/60. And what is even more important, his neovascular membrane, even though it is there, it's decongested slightly. To verify the lack of any vascular changes and inflammation, we did wide field photographs for all the patients. And you see the hemorrhages in his macula disappeared nicely. The granulated appearance of the macula remained. And what is more important, his atrophic changes did not progress despite the intensive anti-VEGF treatment. What is interesting is microperimetry. The disease is still there, and he is having these paracentral absolute scotomas. However, his fixation is getting much more compact because he's using better the residual photoreceptors in his macula. This is the latest addition to the cohort, mother of my colleague, 83-year-old, very classy lady, who is having severe vision deterioration during the first year of lockdown. She was so scared to come out that she practically lost vision in both eyes. To complicate my life, they gave her methotrexate for the last 3 years, advanced neovascular AMD, that is the right eye with the neovascular membrane and diffuse edema, and that is the left eye. You see that it's not that bad. However, there is a racemose type 3 membrane here that is quite well visible in the angio. So what we did, we gave injection for both eyes. She responded. However, the vision in the right did not improve, so we pursued treatment of the left. She improved to 20/80 to 20/50, however, very unstable, and we could not stretch the interval for more than 45 days. December last year, we decided, after incomplete response to Eylea, to give Beovu. On the first day, she already had substantial decrease in the edema. It went on to progress further. Vision improved to 20/30. There were residual spots of edema that regressed nicely. You can see the total regression of the edema for the next 4 weeks. And interestingly, it started on the first day and it went on to continue further after that. That is the wide field, no inflammatory complications, and the atrophic changes did not progress. Now, this is the microperimetry of the patient. As we spoke, the atrophic area is still here. However, the fixation point is more compact compared to the previous one. So basically, this is reflecting the large database collected in the States with the rate of complications in both the iris and Komodo. The findings are similar to the Hawk and Farrier, and the risk is higher in patients who had previous inflammation and retinal occlusions. Obviously, we need to be ready and prepared to monitor the patient and mitigate the inflammation if it happens. And of course, we need to differentiate it from the infectious endophthalmitis. Our indications are persistent fluid despite intensive standard treatment and switch, with severe recurrences, unstable and deteriorating vision. And these are elderly, frail people who have difficulties attending frequent appointments. Most important, to screen for risk factors. The procedure was tolerated very well. We monitored the patient intensively, and the results are quite impressive. Tolerability, fluid resolution from the first day onward. Some of the patients we extended from the first injection, some others we left with the loading dose. And thank you for the time being. That is all. If I have more things to report, I will be the first one to say. Thank you.
Thank you very much. Thanks a lot, Dr. Maya. This excellent presentation and good experience in new drugs for treatment on AMD with AMD. Okay, we are on time. If anyone want to comment, we have 1 minute. Dr. Majdi, Dr. Sibel, Dr. Abdullah, or any questions to Dr. Maya? Do you have any experience, Dr. Majdi, on Beovu? You are mute. You are muted. Can you unmute yourself, please?
Sure. I'm sorry. We don't have Beovu in Egypt yet, but thanks God that Dr. Maya has no complications up to now, because I've seen some of the complications you have to deal with your heart, not with injections. So I hope she will not get any complications in the future. But I
Dr.
don't have
Abdullah?
much experience with that.
Yeah, we have some experience with it when it was introduced over the last year, but due to the recent safety alert, we were really concerned about these uveitis and vascular occlusion side effects, which was highlighted on the American Society of Retina Specialists. We haven't experienced any of these complications, but again, we now stopped it. And fortunately, we have some hope coming on the pipeline from the APC bar, so hopefully will give us some hope in the near future. But I'm aware that many departments across the world stopped using it for the same reason, because you end up with very dreadful complications, and where if you experience vascular occlusion, you end up have nothing to do, if you got what I mean.
Thank you, Dr. Abdullah. Dr. Sibyl?
Actually, I have no experience, but I am thinking about that the good effect of the drug, and maybe in the future we won't use it as a first treatment of choice, but after, in some cases, maybe 20% of the cases, we can use this drug carefully.
Okay, thank you very much. If you allow me, I have an experience with using actually BioView. And I have also an experience in the naive patients, not only on those they are, I mean, they are not responding to another anti-VEGF. Yes, there is a chance of having this complication, but actually for the response is, I mean, magic. I mean, the effect of drying of the macula. But, you know, you have to do the balance between the benefit and the effect. Sometimes, especially, I mean, of those, they are not responding very well and you are not getting any chance to improve. Sometimes you have to think and balance between the side effect, which is very small. I mean, if you want to say it, it's there, but it's very minimal one, which is the less than 1%. Let us forget the 11%, because the 11% is sometimes it's only a uveitis, anterior uveitis, you can manage easily, but the vasculitis or that one, it's very less. I know there is an alert, but still one of the weapon that we have to use whenever we need.
May I have a small comment, please?
Please, yeah.
Just one sentence. We need to switch faster. We need to switch to brolucizumab before the atrophic changes in the retina have advanced. Even if we resolve the fluid with our BioView or faricimab or whatever we are using, we will not be able to recover the vision. So our switch needs to be made at a very appropriate time in the disease. Thank you.
Thank you very much. If you can just please show the screen so I can introduce the next speaker. Oh my God, this is the most famous person.
The last speaker.
No, the last but not the least.
Okay.
My dear friend, Dr. Majdi, is a professor of ophthalmology. We are consultants. I think everyone know him. No more need to introduce, but he is also a director of Medical Retina, Faculty of Medicine, Tanta University in Egypt. He is going to present non-exudative wet AMD versus dry AMD with subretinal fluid. Dr. Majdi, please.
Somebody's still sharing the screen, because I tried to share, say that some of the other participants sharing the screen.
Can you please stop share? I don't think there is a stop share.
Thank you, Dr. Muhammad, for the kind invitation, for always teasing me at the beginning, at the end. But I like you. My presentation today is a bit weird. It's a wet, non-exudative AMD versus dry, non-vascular AMD with subretinal fluid, which means it's wet, but how it's non-neovascular, we'll check it now. I'm glad Dr. Abdullah Laban is here, because of the last publication he had with the multi-centers speaking about this entity. Let me go first about the well-established non-exudative wet AMD, which we call silent CNV, quiescent CNV, intermediate CNV, or whatever we call it. It's a CNV discovered in the other eye of well-established neovascular AMD. It has no sign of activity like we see here on fluorescein angiography or on OCT, only Rpe detachment. There is no fluid, there is no exudation, there is nothing leaking. And it's only diagnosed by OCTA. We find some high vascular flow neovascular complex at the level of the outer retina. and vision is usually not affected, and the patient is not complaining. And it's called, as I said, many names: non-exudative wet AMD, silent CNV, subclinical, quiescent CNV. And these are all the publications started 2015, 2016, up to 2017, using OCTA. At that time, we discovered there is something cooking under the elevated and irregular Rp detachment. So when I started to see this patient, I had also a swept source OCT since 2015. I was one of the few in Egypt who had it. So this is a case of 56 years old female patient presented with well-established CNV in the right eye, type 1, and silent CNV in the left eye. So I asked myself, should I observe? Should I treat? And at that time, I thought if I treated this patient early, I would prevent the progression of CNV. We didn't have much data about that. We only knew that there's something called silent CNV. So I asked myself, how much closer so I observe if I'm not going to treat? And how can I follow her up? Because she has no symptoms, she has no fluid on OCT. Shall I follow up by OCTA? And should I treat by anti-VEGF? And I did treat this patient. So I gave her anti-VEGF once, nothing happened. And I said, how come? There is nothing. Because there is no flattening of the RPE and the patient is not complaining. And she told me, I don't have any changes in my vision. So we started to follow up this patient. And this is 3 years later, almost the same, changing in the shape of the Rpe detachment, the irregularity, but she has the same thing. She has no difference. So I started to say, I treated a couple of other patients, then I stopped treating this patient and only follow up by OCT and OCTA. So this is another example on the other side, a patient who's well-established disciform scar in the right eye, 67 years old female, and a left eye, she had a silent CNV. It doesn't look like a CNV on the fluorescein or OCT, but she had this very low flow in the sub-RPE space at the OCTA. And I said, let's follow up this patient. 6 months later, this is the picture. We have fluid, subretinal fluid, mild intraretinal fluid, and more activity in the OCTA. So a patient is complaining of metamorphopsia, drop of vision, 2 lines. So 1 month later, with anti-VEGF, 6-12 vision. So she still in follow-up with me, I gave her only once, and I didn't have to repeat that. And this is what I found. Eyes with subclinical macular neovascularization should be closely monitored for exudation. Otherwise, you should not treat this patient as early as you think. And this is one of the publications I like, Dr. Rosenfield, who had many publications about the silent CNV. And he said that the prevalence is about 6 to 27% in the other eye of well-established CNV. You can find the silent CNV. And the incidence of exudation will range from 20 to 80% in reviewed studies. So many studies saying that some of them progress rapidly, some of them not progressing rapidly, but from 20 to 80%, which is not a small number, some of them develop active CNV or exudative CNV. And he said it's asymptomatic condition, as we said, and seems to be precursor of formation of exudative neovascularization and evidence suggesting a protective effect of this elevated retinal pigment epithelium. So we should not flatten this or should not treat this. So we might get a geographic atrophy, and we should treat this and only when we have signs of activity on OCT or progression on OCTA in the size and dimensions. So the term neovascular AMD should be preceded by either exudative or non-exudative. This is new in the last 5 years. Let me move to the second part of my presentation. Non-neovascular AMD with subretinal fluid. How it's non-neovascular and it has fluid? It should be neovascular, because we always said, and in my presentation in a couple of minutes ago, once there is fluid, it's active. So this is a patient 2013. This patient presented to me 2013. There was no OCTA at that time, only OCT and fluorescein angiogram. She's a female, 59 years old, bilateral progressive diminution of vision for 6 months. She had no systemic illness, 660 vision in both eyes, no error of refraction, anterior segment unremarkable. And this is the fantastic picture. It has multiple drusen, Resinoid Rp Detachment, yellowish discoloration at the posterior pole, vitelliform-like lesions, and look at the OCT. Huge elevation of the retinal pigment epithelium with sub-Rp hyperreflective material. Overlying the RPE, there is hyperreflective foci and serous detachment. And this is both eyes, fluorescein in both eyes. And this is fundus autofluorescence showing the hyper autofluorescence of the vitelliform-like material. and this is right eye, and this is left eye, with more fluid over the retinal pigment epithelium detachment and hyperreflectivity related to the vitelliform-like deposits we see in the color photo. So at that time, I said, 2013, I didn't have any experience in a case like this. It could not be a CNV. And I didn't have OCTA at that time to exclude. So I treated the left eye. Twice anti-VEGF, nothing happened. The patient felt no difference. The vision was stable, and the Rpe detachment was almost the same. There was no change. So I decided to follow up this patient. So this is the natural course. 9 months after the follow-up, you see, 9 months after the follow-up, this is the horizontal, oblique, and vertical line scans. The Rpe detachment started to flatten with, of course, destruction of the outer retinal layers. And this is 1 year later, almost complete flattening of the Rpe with minimal elevation of the retinal pigment epithelium and destruction of the IS or its junction. Still, we have multiple hyperreflective intraretinal material, which is related to the vitelliform-like deposits, but the vision is 636. Here is the right eye with the revolution, and this is almost 1.5 years later with complete flattening of the retinal pigment epithelium. How about the left eye? Well, I injected it twice, nothing happened, but this was a resistant eye, and this is after 9 months. You can see still we have elevated retinal pigment epithelium. There is no more fluid. Even the hyperreflective material is less, and this is 1.5 years later with complete thinning of the outer retinal layers. All the ellipsoid zone, the RPE, the retinal layers, complete thinning of the outer retinal layers. And this is the macular map showing the resistance of the case. And this is almost 2.5 years later with complete destruction of the outer retinal layers. And the patient did not improve much except 560 or 660 on the. So this is the paper I was talking about, which is a recent one, multiple center. You can see Dr. Laban name on it because it's a multi-center study calling non-neovascular age-related macular degeneration with subretinal fluid. When you read the title, how it's non-neovascular with a fluid, and they tried to evaluate this kind of patients, and they concluded that there is a kind of non-neovascular with subretinal fluid with hugely elevated retinal pigment epithelium, and there is no macular neovascularization there, but they used all the imaging modality to exclude the CNV. If there is any CNV on OCT or OCTA, they consider it as active CNV. And they have 3 patterns in their publication. The first pattern we see on the left side, the one like my one, was I highlighted with the arrow. This is exactly like my patient, huge elevation of the retinal pigment epithelium with the vitelliform-like deposits, and the subretinal fluid is over the crest of the retinal pigment epithelium and complete flattening with loss of the outer retinal layers. The second type, the Resinoid Rp Detachment, and the fluid located minimally at the edge of the crypt of the pigment epithelium detachment, and also complete resolution with what they call it complete RPE and outer retinal atrophy, or they call it C-RORA. On the right side, the last one or the last pattern illustrates the Resinoid Rp Detachment with low-lying drape of subretinal fluid, minimal fluid. You can see it here over the huge Rp detachment seen in the center, and again with the progression also loss of outer retinal layers. So my take-home message from the first part of my presentation, OCTA is the only capable imaging modality revealing silent CNV, and we have to rely on it to find out this CNV. We don't treat it, but follow up these cases by OCT or OCTA is the method of choice in evaluating the activity. And incidence of exudation, as I said, 20 to 80%, and no treatment till the CNV shows exudation sign on OCT. On the second part, this is a new entity. We call it non-neovascular AMD or Rpe detachment with subretinal fluid, which is described, as I told you, by this paper, with fluid in the absence of evidence CNV using all the multimodal imaging and pathogenesis. They suspected that hypoxia-induced RPE pump failure due to the large distance between the outer retina and the RPE from the underlying corona. This is the cause of fluid accumulation. And non-neovascular AMD with subretinal fluid is an important clinical entity to recognize to avoid unnecessary antivascular endothelial growth factor. We should not treat this patient, and we should follow them up, and probably they will end up with atrophy of the outer retinal layers because there's nothing to do in these cases. Thank you so much for your listening.
Thank you very much, Dr. Majdi. As usual, very nice and excellent presentation. You know, the last but is not the least. We are all the time learning everything new from your side.
Let me hear Abdullah Laban commenting on this.
Fortunately, there is Dr. Abdullah today, and he is participating on that. So I don't know. We can ask him or not because he is the one.
He's smiling. He will answer. He's smiling. He will answer that. He will smile. He will tell us what's in between the lines. He has to know.
Okay, Dr. Abdullah, okay, we need to highlight this point, more. What is really, do you think, is the pathophysiology, or we are just anticipating this, and we can, why it's resolving? I mean, why after 1.5 years, like in the case of Dr. Majdi, what is the reason that there will be a resolving? What is happened so that make that resolve and change on this huge fluid and it become normal?
Yeah, thank you very much, Dr. Mohammed, and thank you very much, Professor Magdi, for the excellent presentation and highlighting this is actually a really important topic. Talking specifically about the non-neovascular AMD with subretinal fluid. Yeah, it's a bit unusual to get some subretinal fluid without any neovascular component. And there are two mechanisms behind that. One could be a fluid exudation or a fluid transudation. Unfortunately, with our current multimodal imaging tools, will not be able to prove or rule out the transudation process. So the mechanism for that is just postulated or that's hypothetical in the study. And could be also, in addition to that, like a pump failure, one option could be like a mechanical option as well. And those patients without any neovascular component, the tricky thing is that once you start to see the dome of the BED, you normally see like a smooth dome or something like that. But once you start to see the dome slightly irregular, this be the start that it will regress and atrophy over time, and you end up with at complete atrophy of the outer retina. And it usually takes some time. But the main point is that we try not to inject these cases because injection will not do anything. The other component, if I understand the question correctly, is relation to those with inactive CNV. Is that correct?
Yes.
No,
I mean, now non-vascular.
No, he's talking about the last part of the presentation. I mean, he's talking about this huge retinal pigment film detachment. Abdullah, let me raise another question for you. Some of these cases have vitelliform-like deposits, which looks like a vitelliform dystrophy, and some of them doesn't have. Do you think this vitelliform type could be the exudative one and the other types is the non-exudative one? Because this could be another classification, because some of these cases have huge vitelliform-like deposits, which is transudation, and the others doesn't have, and it could be, just transudation, and the other one is exudation. I don't know. This is my notice, because I don't see many of these cases. I see a lot with subretinal fluid without this vitelliform deposits. And I used to inject these patients before the OCTA thinking that this is an active CNV. But now I always take care that even with the flat irregular Rpe detachment, with nothing under it, I will never dare to inject this patient, because I think we are pushing this patient into more and more geographic atrophy or destruction of the outer retinal layers, as Dr. Rosenfield was using the term like, friendly fire or friendly Rpe detachment, or silent CNV is a friendly CNV, which prevent the collapse of the retinal epithelium and prevent more and more destruction of the outer retinal layers. What do you think about that?
Can I ask a question, Professor Macular?
Okay,
because of your excellent experience, can we actually consider that some of the non-neovascular macular degeneration is actually a late onset hereditary macular dystrophy?
Okay, I think Abdullah, if you can answer these two questions, Dr. Majdi and Dr. Amaya, in a brief, please. So
Abdullah, start your answer, and I will answer Dr. Maya. Please answer the first question, and I will end up with answering the second question.
Yeah, we need a brief, Dr. Abdullah. Sorry, we are already late.
I think when mentioned on this study, it was mainly focusing on those with Resinoid pigment epithelial detachment. So you have the drusen and drusen detachment, and you get subretinal fluid, or what looks like a subretinal fluid in the scan, like hyperreflective area, could be on the top of the BED, or could be the edge, or could be like a very thin layer over it. But we also see sometimes the vitelliform lesion, which is above the RBE. So it's above the RBE and it's subretinal. And sometimes you see within like homogeneous vitelliform lesion, but sometimes over time you see like hyperreflective area. Again, in these two conditions without any evidence of CNV. What also Dr. Magdi highlighted in the first part of the presentation very nicely, those where you get a new vascular component, but it's inactive. And sometimes these patients present with what we call undulated RBE. And under this undulated RBE, you can be a very low flow CNV. Sometimes actually this is a true low flow, and sometimes this is like artifact we are getting from the OCTA. But I totally agree with Dr. Magdi. No, we don't treat unless you see definite exudative features. And in some cases, if you are not really sure, you can wait a little bit and see. Usually these cases, if they are turning or will turn towards the exudative side, you'll see more exudation. You will repeat the OCTA, you'll see like more mature branching network. And you start the injection with confidence. In a very rare situations, you can do like a trial of injection, like just a loading dose of 3 injections and see how they respond. But with what is thought to be like new vascular component there. But if there is no new vascular component, my feeling, we can just observe for now.
Okay, thank you,
Thank you,
Abdullah.
Dr. Abdullah.
Okay,
You want me to
Magdi,
answer,
if you
Dr.
can.
Maya?
Yeah.
Yes, she was
Very
asking
fast,
about
please.
like late onset macular dystrophy. But I don't feel like this, because I see a lot of patients with adult form vitelliform dystrophy, but this is completely different. We don't see this patient with this huge Rp detachment. We don't see them with the sub-RPE Resinoid material or hyperreflective material. We always see a small vitelliform lesion in the adult form. It is not that widespread, or it's not that extensive. So that's why I'm saying adult form vitelliform dystrophy is a complete different entity. Sometimes they develop CNV in that, but it's completely different entity from the presentation here, because the huge Rp detachment with the subretinal fluid or even the silent CNV is completely different. And thank you, Dr. Maya, for the question.
Thank you very much. I think we can see only the pre-recorded, if you allow me, because for our doctors, can you share the... Yes, Dr. Raja, he will present dexamethasone implant as an adjuvant to anti-VEGF in PCV. Okay. Please share the screen.
At the outset, I would like to thank for giving us the opportunity to present our work on combination of dexamethasone implant and anti-VEGF therapy in treatment-resistant neovascular age-related macular degeneration. I have no financial interests or relationships to disclose. Off-label use of dexamethasone implant and bevacizumab will be discussed. The objective of the study was to evaluate the efficacy of a combination of dexamethasone implant and anti-VEGF therapy in eyes resistant to anti-VEGF monotherapy in age-related macular degeneration and polypoidal choroidal vasculopathy. This study was conducted at LV Prasad Eye Institute, Hyderabad, and this was a retrospective study. 17 eyes of 16 patients were enrolled. All subjects were injected with intravitreal dexamethasone implant and either 1.25 milligram bevacizumab or 0.5 milligram ranibizumab. Patients with subfoveal CNVM or PCV and those who had received a minimum of 3 consecutive monthly anti-VEGF injections in the previous 12 weeks with less than 10% reduction in central subfield thickness were included in the study. Patients who had prior vitreoretinal surgery or anticipated within the next 12 months, those who had glaucoma, or had decrease in visual acuity due to causes other than CNVM, and those who had received intraocular or periocular corticosteroids in the study eye in the previous 6 months were excluded from the study. At baseline, patients underwent visual acuity testing, dilated fundus examination with slit lamp biomicroscopy, color fundus photography, fundus fluorescein, and ICG angiography, as well as OCT. At subsequent visits, patients underwent visual acuity testing and OCT. Patients were evaluated again after 1 month and re-injected with intravitreal anti-VEGF if there was persistent intraretinal or subretinal fluid. The primary outcome measure was the anatomical response on OCT, and the secondary outcome measures were gain in visual acuity and injection-free interval after dexamethasone implant along with anti-VEGF injection. 17 eyes of 16 patients were included in this study. The mean age was 69.3 years, and there were 9 females. 12 eyes had PCV, and 5 eyes had neovascular macular degeneration. The mean number of prior anti-VEGF injections was 4.5, and the mean follow-up of these patients after dexamethasone implant with anti-VEGF treatment was 11.2 months. There was a significant reduction in the macular edema as seen on OCT. The mean OCT thickness reduced from 612 microns to 306 microns at the last visit, and this was statistically significant. The visual acuity was not statistically different from the baseline visual acuity at 1 month as well as last follow-up. There was a good correlation between baseline visual acuity and post-injection visual acuity. The mean injection-free interval in these patients after dexamethasone implant was 169.8 days, which was significantly greater than the pre-injection interval of 35.2 days. This is a patient from our study who had received 3 monthly ranibizumab injections with poor response as shown in the top 2 figures A and B. Figures C and D are images taken after the combination of ranibizumab and dexamethasone injections seen at 3 weeks and 2 months after the dexamethasone implant, which showed complete resolution of the intraretinal fluid as well as significant reduction in the pigment epithelial detachment. This is another patient who had received 4 bevacizumab and 1 ranibizumab injections with very poor response and a significant macular edema. Figure B and C show complete resolution of macular fluid after ranibizumab and dexamethasone implant 1 and 6 months after the injection. In conclusion, dexamethasone implant combined with anti-VEGF treatment can restore foveal anatomy in eyes resistant to anti-VEGF injection while maintaining visual acuity. The burden of frequent injections can be reduced with the addition of dexamethasone implant. These are my references. I would like to thank my colleague Dr. Srikant Padi for helping me with this presentation. Thank you for your kind attention.
Thank you very much for all. I think Dr. is not with us. So is there any comment, Dr. Majdi, Dr. Sibel, Dr. Maya, Dr. Abdullah, before we can conclude our session? We are 20 minutes behind our time, but we are the last session, so it's okay.
Well, I'd like to thank all
for Dr. Majdi to sleep. Very nice.
No,
for
I'm
Dr.
going
Abdullah.
out now.
I am the only one
ready to go out. I'm ready to go out now. By the way, because this is the weekend. You killed the weekend, 3 o'clock and 8 o'clock today. My wife will kill me because you killed the weekend. Anyhow, I would like to thank all.
You have seen me. That's more than enough. She will not kill you.
I will see you in my sleep. in my dreams. Thank you very much for everyone. I really enjoyed that. I learned a lot from every lecture, and it's very good to share our experience with each other. And thanks again for all the participants. Thank you, Dr. Muhammad, for gathering this. I know how much hard you had to work, and pray for us for the next 2 days to be there with you and quick. Thank you so much.
Thank you very much, Dr. Majdi, Dr. Sibel, Dr. Abdullah, Dr. Mayab, Dr. Brasan, and all the team. Thank you very much for all this support. Without you, we cannot do one of these things. Thanks, Dr. Majdi. You are one of those. You are preparing with me many times for these sessions. Thank you, and we will see you, inshallah, in the next 2 days. Thanks a lot. And
my pleasure. Good night.
Bye-bye.
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 Thank you very much, Dr. Muhammad.
Thank you.
Thank you very much, Dr. Muhammad, for this kind invitation, and hope we meet in person in the near future. And
inshallah, we will prepare, inshallah, for Myom. We hope to see you, inshallah, in Dubai in this year, inshallah.
And thank you, Professor Magdi. It was always a pleasure to meet you, and hope to see you meet each other like the old good days. Inshallah. Nice to meet Dr. Saibel and Dr. Maya. Hopefully we'll catch up at some point.
Yeah, I hope so. Thank you very much. It's my pleasure. Bye-bye.
Bye-bye.
Bye-bye. Good night.
Thank you, teams. Excellent job. Thanks a lot. See you tomorrow, inshallah.
Inshallah.